Welcome to Airway Answers, expanding your breadth of knowledge. My name is Nicole Goldfarb, and I'm a speech-language pathologist and certified orofacial myologist. And I'm here to help you find your airway answers. We're in this together. Let's do this. Hello, everybody, and welcome. I'm here with Dr. Who. Hello, Jerry Who. How are you?
Wonderful. How are you, Nicole?
Good. We're all here to find our airway answers, right?
Yep, absolutely.
The whole world, we're all searching for airway answers. And I am so delighted to have you here with me today, Dr. Who. I have a lot of questions for you. I see you a lot on social media, all these things you're doing. I don't know how you find time to do everything you're doing. You're on the news, articles, everything. So I'm going to read your bio, and then we got to break down all that you do. So Dr. Jerry Who, now first off, you have about 1 million letters after your name. This is crazy. Like, I'm just going to read them because this is amazing. It takes up a full line on my paper. DDS, DABSM, DACSDD, DASBA, MICOI, FICOI, AFAAIG, LVIF, FIAPA, FIADFE. Oh my gosh,
Yeah.
we should say that as
so
fast
before I went into dental sleep medicine, I was very much involved with implant and cosmetic and full mouth reconstruction. So that's where the other credentials come from. Yeah.
Oh my gosh. Okay, because I was gonna ask, like, what are all those? That's a lot of titles. You have done a lot. So before you went into dental sleep medicine, it was cosmetic dentistry.
And full mouth reconstruction and implant dentistry. So I'm the kind of guy that fully dives in. So if there is any credentialing bodies or, any type of process where you have to kind of prove yourself, I kind of just jumped in fully to do so.
I can see that. Oh my gosh, this is great. You have a lot of information. So Dr. Who has been lecturing, doing clinical research, and practicing full-time dentistry for over 27 years. He lectures internationally on cosmetic and implant dentistry, as well as on his greatest passion, which is in the field of dental sleep medicine. He has won numerous national awards in cosmetic and full mouth reconstruction dentistry. Dr. Who has been published in several peer-reviewed, world-renowned dentistry journals such as the JDSM, JCD, Aegis Dentistry Today, DSP, and his work even landed on the cover of the highly regarded peer-reviewed Journal of Cosmetic Dentistry. He's also adjunct faculty at the Medical University of South Carolina, teaching the first interdisciplinary sleep medicine curriculum to medical M4, dental D4, and fellows residents of the university. Congratulations on that. That's huge.
Thank you.
Dr. Who also teaches at several annual national meetings and sleep medicine conventions and several online webinars, clinical forums on social media, and teaches for several dental academies and organizations, and has taught for many years for Sleep Group Solutions, Modern, Global Microdental USA, and also for several other state-level dental societies, such as the Missouri Sleep Society and North Carolina AGD. And this is also awesome. You were the keynote speaker at the annual Asian Pacific Dental Sleep Medicine Fellowship in Singapore in 2024. That was like just a couple weeks ago, right?
Yes. That was a 17-and-a-half-hour flight from LAX nonstop. So that was a long flight for sure.
Oh my gosh. What an honor, though.
So thank you. Yes, it was wonderful. And for Asia, yeah.
Keynote speaker. That is so great. So we have so much to talk about. I know we want to talk about different treatment options and choices for all of dental sleep medicine.
Yes.
And I think we should make that a big focus, talking about patient and practitioner choices and what can be done for our patients with sleep breathing issues. But let's do a little background on who you are and how you got started, first in the field of dentistry, and then what led you to be interested in dental sleep medicine as a specialty?
Wonderful. So, like a lot of times in the dental sleep medicine part, it's always ourselves or family members, but I'll kind of lead into that. So after I got out of dental school, I was, raised in Alaska. I was born in Taiwan, but, I was a non-resident, out-of-state tuition, had a huge, burden of debt like anybody out of dental school. But I went on a program where I was a full-time practicing dentist solo at age 24. So it was a lot of debt, a lot of pressure. So I said to myself, I really got to find a way to not only just from business aspect, but also really do this goal in mind that just because I'm from rural Alaska, it doesn't mean that we can't offer the best, the latest state of the art. So I immersed myself right away in massive continuing education, not just on like the several different camps or schools that you would think of, from neuromuscular to CR to all of it. I wanted to embrace all of it so that anybody who walked into my office, whether they're treated with TMJ, TMD, with occlusion, with whatever philosophy, that I at least understand the philosophy and the principles behind that, so then I can best lead them to a better clinical outcome, right? So when I did that, it was at that time real well known. There was the Extreme Smile Makeover show with Dorfman. There, this is before even implant dentistry was the it thing, right? So fortunately, I was able to, because of that goal in mind and perseverance and stuff like that, I was able to kind of ride a wave, if you will, instead of chase a wave. So I was very, very lucky with that. And then all of a sudden, implant dentistry hits. And so, it almost became taboo right away to do a fixed bridge, right? You had to do everything. And, in the beginning, on ICOI, AID, they were all saying, oh, well, if you do implants, it has like a 99% success rate. And I'm like, okay, well, what about 5-year, 10-year longitudinal? What about, periimplantitis, perimucositis? What about occlusion? What about low? So that kind of led to more and more. And I really feel then this is the part, my best favorite part is how I got involved in dental sleep medicine. So I feel that it's really a calling because first of all, growing up, my whole family had sleep apnea, snoring, sleep breathing disorders. And like the usual, you don't know what you don't know, we even just laughed at each other, even when we're having acid reflux episodes all the way to choking, gasping for air. And the issue then, of course, that we see throughout the world, and I know I just kind of saw your podcast with Roger Price about some of the real scary detriments of the world, because knowledge is power, but when people don't know what they don't know, or when physicians and the people in the medical field aren't trained to really not just screen but also look at the different current studies and keep up with it to see what's effective versus efficacy, what is mean disease alleviation, what is all those things, and what that ties into, and of course there's always the power of big pharmaceuticals, there's power of big industry, big money. So and so with that, it kind of, now, I've lost both of my parents. I lost my dad 2.5 years ago to Alzheimer's, dementia, and congestive heart failure. I lost my mom the day before my birthday last year. She had renal failure, being over 40 years, decades of antihypertension medication. It did a toll on her kidneys, so she had kidney failure. She was on dialysis. And at the kidney center, they took way too much fluid out on her here in Vegas. So her electrolytes were off balance. She had a heart attack and unfortunately passed away. So those things in my mind, and especially on my dad's journey, I know that because I kind of involved myself and got into it. He went through the BiPAP, all the PAPs you can think of. With Alzheimer's, it gets tricky because sometimes he'll trip over cords, and when it got to stage 6 and 7, he would actually just it's like the movies. He'll go to the bathroom, or he'll on the floor in the living room or whatnot. So I had to change his diapers, and I'm really thankful that I actually did. I mean, he changed my diapers as a baby. So right, so
Yeah, give
it's
back.
really good that I'm looking back. I'm thank God that I was there, towards his latter part of his life and be there. But the most important thing is man, there's that aspect and all the issues that not one neurologist, that not one cardiologist, not really dived into my dad's sleep and breathing, right? And so that is like, hey, this is something really, really through my dental education, how much was really dental sleep medicine in the curriculum, not zero at all, and for some of the primary cares, it's getting better. Years ago, it was said that maybe 2 to 3 hours of elective training is all, through residency a primary care physician would get. So that's a big major issue. And then for myself, I've always been kind of overweight. I was, and again, I didn't know what I didn't know, especially when I was doing really well in cosmetic implant dentistry. I mean, I was getting upwards near almost 400 pounds, right? And so you can imagine the hypertension, the medication I was on. I was totally like, swallowing those Nexium purple pills left and right because I would have acid reflux. And it's just like, wow. And so, going through getting myself treated and getting proper sleep, and then you think about leptin, ghrelin hormones, and everything else, I'm able to really say, this is something that I think is just beyond what your calling is. You thought go through dental school, you're going to be like, oh, I'm going to be doing fillings and crowns and bridges and smiles and stuff like that, which is rewarding, and you change lives with that. But this is life saving. This is life promoting, and the prevention aspect. And so when I've lost the weight, I got my black belt in karate. I've had hired an Army Ranger personal trainer, and he got me to do things that I never thought I was able to do, like toes the bar and certain like almost Cirque du Soleil moves. But anyway,
That's awesome.
so that's kind of like my passion into that. So then going into this, as I see. And I'm so glad we can talk about these different options, and maybe we can even separate a little bit of pediatric versus adults. And I can just kind of start off by saying, and if I do too much run on and stuff, like just stop me. If any questions, because I can just go on and on and on. Okay, so if you look at this prevalence of treatment and what's current, obviously CPAP is still, quote unquote, the gold standard, and it's the most used worldwide. The next would be the oral appliance therapy with mandibular MRDs, MADs, MAS, whatever you want to call them. And then, third, which does have a lot of good evidence base, but it's a little bit, in my humble opinion, a little bit more invasive, right? It would be the MARPI, SARPI, DOME, MSC, Swan Moon. Those are definitely there, okay, and they're an option. Of course, there's Inspire. Of course, then you go more and more invasive. You can have MMA or trach. I mean, you can go on and on, right? And the part that is really missing, and because I feel that sometimes when in any profession you get people who try new modalities, or they try different treatment options. First, number one, they could be impatient. Number two, they don't really understand the dynamics and the importance of each protocol or each type of option. For example, if you were to do a DNA appliance versus a AGGA appliance versus a homeo block or pod versus OC or a Schwartz or a bionator or a Rickinator, there's so many different protocols and options, right? And again, when you start either rushing or you don't follow a cookbook, a lot of times these options, the original people that kind of did the research and did the plan of treatment and the steps, they really put a lot of thought, and they had a lot of trial and errors, a lot of failures to bring to where they're at. And if certain, maybe cowboy or wild dentistry goes on, or maybe sometimes is neglectful, like, a lot of dentists, they just want to put, more case completion so they can maybe say, oh, I did so many cases per month or whatever, and not really think about the patient, put the patient's best interest first, then things can go wrong, right? And everybody's heard of that, $10 million lawsuit from New York with that clarinet player. And, part of it is really the supervision of it. The doctor's an excellent doctor, and I think, people who know her, why not? But I'm not mentioning any names. But anyway, sometimes things like that are unfortunate, but then when it becomes also public information or public, in the news, it's really a slam against all of us in airway and sleep medicine, right? So it's one of those things where I feel we have to, because the awareness is so low and there's so much that we can impact upon, we really need to understand, stick together. And it's like podcasts such as these, webinars, seminars, conventions, that really needs to bring the word out, because we know, to the physicians, to the rest of the world, we got to show not just our research, but we have to show clinical outcomes that are successful, right? That are really, exemplary of what we can do, because in the end, the world benefits. When you think about the project that Roger's doing, I was just really thinking about it over last night. Even what a wonderful, neat design program, right? Where you can influence, and he's got the right group of people there. From speech pathologists to behavioral counselors to psychiatrists and stuff like that there, along with, dentists to intervene at, age 3 to 4 to 5, and then compared to the control at 6. But moreover, he's also really right that we have more battles because of technology nowadays with, even basic sleep hygiene to nutrition to all of that. So I wanted to kind of touch upon that this non-invasive also has multi-complexity layers. Okay, for example, when you are thinking about a three-way short or a DNA appliance, it's really trying to tap into the stem cells, right, in the PDL space for expansion. But then there's also, when you think about the anterior growth guidance appliance, the philosophy for that was to tap into the mesenchymal cells and the maxillary tuberosity and the mandibular ramus. So you kind of got to know, what areas are you putting force in, what areas are you stimulating, and how do you go about it? How do you go month to month? A lot of times people don't understand what's going on, but these live dynamic options, I consider MRD, oral appliance therapy, a static option, right? Because you're going to find a therapeutic position. You're going to hold that jaw throughout the night. It's to keep the airway patent as best as possible, but it's something that's just kind of making sure that the tongue and jaw and the mandible, the highway doesn't fall back. But if we're doing something like growth guidance or osteoremodeling, this is a live dynamic. And this is where so much of it is important, like what, again, I'll refer to Roger because he's fresh on my mind. It's a complete total body interdisciplinarily approach, right? And then I think if you get into even further aspects, you got to talk about cranial strains. You got to talk about distortions, torsion, side bends, okay? You have to talk about how the body compensates and absolutely the occlusion, okay, and everything about it in connection with posture, your cervical vertebrae. And also, we have to look at things, are things descending or ascending, right? If you have a longer leg versus another leg, wear a corrective shoe. One side's always going to be more load, more taxed, right? You'll have SI issues that you need to see SOT. Maybe you have to wear a trochanter belt or a core wear underwear, or you may have to have a foot orthotic. Those are very important, right? Because every time when we're off balance, the body has to compensate, right? We want to be nicely level and balanced. Now, there is a very wonderful guy by the name of Dr. Bob Walker. He is a chiropractor, SOT. His He works with Kay MacArthur, and she is an AACD dentist, also works with them. But they do cranial manual release of sutures. Now, back in 1924, there were already studies that were published that say no, certain sutures don't even quote unquote fuse until you're like 80 years old. So the notion or the idea in dental school, medical school, where they say, oh, you can't move sutures to just fuse together. Now, of course, when you look at the palatal suture that maxillary skeletal expansion too, you're taking massive forces to split that suture and create a huge diastema. Sure, and it's wonderful. The evidence base is there. Juan Moon did a lot of studies with that. I get it, but the sutures, squamous cranial sutures, there's 29 bones in the skull, and then we have those cranial bones, right? And then we have the facial bones, and then we have the inner bones like the hyoid and the inner ear, all that stuff, right? But the cranial bones, with that squamous suture, you can release that and you can manually. Now, for me, when I had that done to me, it was really crazy, right? Because Bob looked at me right away and he said, Jerry, just stand right there. I'm like, okay. He says, you have a lateral strain. Your eyesight is low on this side, your ear's there, your maxilla's there, and I'm blah, 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 blah. So I'm this big zigzag. I'm like, okay. So he released my cranial sutures, and holy cow, he dropped my maxilla 3 centimeters on one side. I mean, and then we were doing this live recording, right? So, and then I stood back up, and everyone in the room, all the attendees can see that I'm level. And it was really weird. It felt like I was in a roller coaster ride, but it was more euphoric because, like, I've never been really level in my life. And he says, "Well, Jerry, this is what happens. This is why I don't like to teach any chiropractor or dentist alone. Every time I do a seminar, I want a chiropractor and a dentist to be together, because the minute you start functioning, chewing, walking, taking a step into your car, everything that I've done will unravel or break apart again, right? So we have this gap concept, this gap, and then again, this gap concept. When I first learned about chirodontics, it was working with a SOT, with a chiropractor together to do these releases and to level. But there's actually and I have to give credit to Dr. Timothy Adams. We were doing a study club together, and I was showing about my expansion cases, and he was talking about his cases using the unilateral homeoblock and the pod, and creating that gap and understanding the gap. And the way he explained it was, if you think of maybe like a Rubik's Cube, and there's all these things you have to do to put all the colors on one side, He says, wouldn't it be easier if you just put a gap? You pull that middle cube out, and then you can move things easier and faster. And when he explained like that, it kind of gave me an aha moment, because oftentimes our body really wants to get better. There's things in us that we want to do, but we need that stimulus, we need that chance, we need that option, or that appliance in this matter, to do that. And then he talks about the quantum physics aspects. And we know when we have a tongue tie release, the deep for the fascia, right, it's all interconnected. And he's even thinking like, hey, on the level of how we have genetics discussed, where you have DNA, RNA, protein, and it kind of has this classic genetic way. But if you think about epigenetics, think about environment, it goes every way. It goes either way. The environment, how we eat, to how we compensate for a sports injury or our lifestyle or whatnot. It's constantly influencing our survival, right? So we actually are moldable, and with this idea that now in quantum physics, it's more about transduction, and there's biotensegrity. There's all these things that are interconnected, and this is where the interdisciplinary part is so important, because it's not just looking beyond the T, it's looking at the entire body, the posture and airway and everything all connected together. So that's kind of where I wanted to make emphasis, is if there is a possibility that, yes, I fully respect all the MARPI, SARPI, DOME options out there, but if we could get a little bit more attention to these osteo remodeling bone growth guidance, and it's for pediatrics and adults. Of course, much more predictable, much more widely accepted in pediatric, but for adults, I have clinical cases with CT scans that show, no, we did not use these crazy forces to flare teeth out of bone. We follow protocol. We made sure, for example, if I did anterior growth guidance appliance, it's key that the lingual pads are always attached firmly at each interval visit, that they're not detached, because if they are, and that lock spring on the back starts driving that force forward, of course, when that force gets so high, you're going to flare the teeth out of bone. And the anterior maxilla in implant dentistry, everybody knows, it's generally less than 0.7 millimeters thickness. And if you put the force there, you're going to flare the teeth out. And that's what that disastrous case with the clarinet player, what happened there, right? So these things, I think, is almost maybe taking a step back and understanding that never to force any type of these remodeling, cases, but to let the biomimetic aspect, let the body itself. Actually, the DNA appliance or any three-way Schwartz's, if you follow it correctly, you're not really supposed to do any turns on the screw or the barrel. You're not supposed to really adjust the pads or until the appliance gets to a certain level of tightness, right? Then as the pallet drops, as things expand, you go slowly into that. And again, that's the antithesis of the notion where we just want to get things done and we want to rapid palatal expansion, do hyraxes and boom, boom, boom. Well, when you do things too fast, I always kind of tell people you run the risk of dehiscence, bone loss, inflammation, relapse. You have all those things that are in mind. And then another aspect too, where I want to say is a lot of people forget this basic concept. And if I can just kind of go into this basic concept, I know I'm going everywhere and stopping if I'm going on too
This
many
is my sign. This is sign language for more. Keep going. Yeah, I'm
Okay,
writing so many notes
so
here. Like this is so
so
interesting.
I'd like to say this now. There's one person that added one more leg or pillar, if you will. I think of where I'm at in this dental sleep medicine is this table, and this table has four legs. Now I'll add the fifth leg at the end, but these four legs are important, right? Because if you take one leg or one pillar from the table, it's more likely to topple over. And if you take two, then it's easily like you can just topple the whole table over. So what are these four legs part of our quality of life, right? One is sleep, okay? One's nutrition, one's exercise, and one's mental health. Now, you can have any of those legs missing, then you're not going to get the ideal to be your fullest potential day in, day out. If you exercised a lot and you ate great, but you never slept, that's not going to work, right? Or if you have anxiety, depression, you have insomnia, you have a lot of cognitive behavioral issues, but you have the other things right, but you wake up all throughout the night, you're not going to get your proper rest. You're not get your energy, right? And then, of course, there's also the daytime breathing stuff. I'm very, very big proponent of that because we're live airway. It's 24/7. And yes, there's a lot of issues ranging from brain fog, memory, to all that we do every day that's linked to everything that we do in the daytime to really be aware and conscious of how we're breathing. Of course, there's so many different, Buteco with Patrick McGowan. There's, of course, the wonderful things that Roger Price brings to us, about letting our bodies find our own breathing pattern, our own breathing, rates. All those things are really good food for thought, right? But if we remove one leg, then there's a problem. We don't have a very, very, and I always tell my patients, I'm not a nutritionist. I'm not a trainer or expert in sports or exercise, but I can tell you what I went through and how I was able to lose over 135 pounds and how I get the energy because, it all goes together. And the fifth leg that they talk about is spirituality. So if you have some form of spirituality, they say, well, Jerry, that's the center one. That's the one that holds everything together. Yes. And so if you have some spirituality, whatever religion or not religion, or even just like mindfulness, meditation, the universe, that is very, very strong and powerful too. And then that kind of also leads to the quantum physics side where, there's this like transduction, there's energy and there's vibrations and there's all these things that we interconnect with, right? And it's true. I mean, you can look at blood pressure, you can look at all this data on stress levels, how that really is early death. If you don't do anything about it, it's going to definitely take a toll on our mental, our physical, all of that together. Another thing that I think that's very important too, when I was going over Tim Adams stuff, is if you just look at the anatomy and you look at the neurology, you think about the vagus nerve and you think about, oh my gosh, there's so many like things, or the different systems like the hyoid bone. I think of it kind of like the puppeteer. There's so much, if there's a study done in Taiwan, I think that shows the C3 to the mental frame area. If you have your hyoid below that or above that, it's actually a very good indicator of the severity of sleep apnea or breathing disorders. And you have a lot of the retrodiscal tissue, the bilaminar zone, or the condyles. If it pinches in that area, the rictotemporal runs into that. And if you have those, overclosed, very retrognathic patients, there's no wonder all these other orofacial pain, trigger point issues, and things like that kind of arise. So if you look at even from just the anatomical aspect to a neurological aspect, there's so much that our body is screaming and yelling for to say help. And the earlier you intervene, the easier it is. Expansion cases especially way easier. I can kind of explain my youngest. He's a preemie baby. And I've heard you before talk about, your kids and you're doing everything that you can. So there's a really cool optometrist, ophthalmologist, I guess, in Anchorage, Alaska. And they talk about, visual exercises too, as well. So my son, like me, we see uniocularly. We don't see biocularly. And that's actually the way they explain it is, Jerry, if you actually were able to read and see things biocularly, you would be even more amazing. I'm like, oh no. So I was like, okay. She goes, no, like she goes, I'm serious. She goes, if you were reading, because your brain has to, take images separately, but if you actually can see things and learn to train to see biocularly, it's just so much better. So anyway, for myofunctional therapy exercises and things like that. We even took our son to the Amen Clinic, and we did everything that we can. And, we even started with some of like the Vivos, the early starter things, stuff like that. But we can only go so far. So right now I have him on a bionator. And then we're also adding, and it's crazy. And I mean, this is a kid literally that had all those classic, symptoms of tiredness during the day, just a mental like clarity, brain fog, talking to with his friends at school, being in sports. And you see that drastic change, and he's like a key component to the soccer team now. He's doing so well in sports. He's getting A's and B's. And this is, my oldest two, they're very smart. So we're not like traditional Asian parents, like you have to be doctor, you have to be doctor. we're like, let's look at what you like, what you're passionate about. And he always loved soccer. And the one thing that I think they're so cool, now the Amen clinics, they have them throughout the US. They do those brain scans, and they said that my son has a diamond shaped pattern on the basal ganglia stuff. So they actually wrote down, not just adding serotonin and GABA and all that stuff, but also certain exercises like playing with ping pong or reflex things. And so we got him to do that as well and complement that with the diet and everything. And he's just really thriving, and it's awesome to say, gosh, we can do these things to intervene and make them thrive. And so that's kind of, and I guess we're all kind of now so cool speaking the same language, because watching these podcasts and stuff like that, I feel that we are going to hopefully move that needle forward, if you will, and make it to where even at MUSC, this is the first time where in a medical M4 dental D4 level, you have, of course, those the resident programs at USC, at Tufts, but this is like, dental, this is getting them really, really early on before they go out of dental school. And the one component too, I was able to get an academy to offer testing right when they graduate. So when they're day one with all their debt, unlike me going, what do I do? What do I do? They actually have an extra credential in dental sleep medicine to help them get going. And so doing things like that, I think hopefully will change the future, because of course, in the US and Canada, you can't do anything in sleep unless you have the blessing of the board certified sleep physician. They officially have to make that diagnosis. And especially since we're such an insurance dependent country, the insurances won't even look at, beyond any pre-auth or verification of benefits unless all that paperwork is there, right? And then that's fine. I think that's great. But kind of like what Roger pointed out, though, I think so many physicians are completely unaware of so many things about what we can do, and that it is interdisciplinarily, and that we have to work together. But it's only this way. Like, I hope that when Roger has a huge publication, when he's done with the study, that it will be really cited by a lot of medical slash dental schools, so that we can see, like, getting in there when, before the signs are kind of hidden, before all the things that you see are apparent, you're already addressing those habits or catching those issues or any types of dysfunction early on, and then treating that and changing the trajectory of the child.
Yeah, it's so important, that early intervention, because the signs appear before symptoms are noticed, right? And
Yeah.
we gotta just look for those signs. And these issues with posture, breathing, malocclusion, airway are so common that it's almost rare to not have a problem in one of these domains, right?
Yeah.
Like, I go drop my kids off at school or soccer or whatever, and I'm looking at all their peers and I'm like, oh gosh, now even my husband sees it. So we're both like, hey, like, you see it everywhere. And if we could get them at a young age, so early, to start making little changes, these things could be profound, because we're affecting bone growth if we can do it really early, and patterns and compensations. And that's right. I think a lot of physicians are really unaware. And like you said, even for your parents, like at an older age, the cardiologist is missing these things, the neurologist. It's almost baffling to think, that a cardiologist might not be testing for sleep apnea, or
Yeah.
neurologists don't think of these things, or even psychiatrists might not even question about sleep,
Yeah.
or they may say, how's your sleep, or how's the child's sleep, but
Yeah.
nothing beyond that. So yeah, if there's like some great protocol of like 5 to 10 questions that every physician should ask a patient, beyond how's your sleep, and maybe beyond, do you snore, that would be great. Maybe there is something like that that I don't know about.
Well, I mean, of course, all the easy stuff like stopping and stuff like that, even if the ones that are existing or whatnot. But I totally understand what you're saying because especially here in Vegas, actually Vegas is ranked very, very low in healthcare. It may even be behind Puerto Rico. I refused to believe that at first when I moved here, but I kind of can see, oh my gosh, the level of just utter shock, other appalling treatment of patients here. It's just not just hoarding them in and out. I don't know if it's a quota that they have with their managed care or whatnot, but they don't really have much time. So if there's something that can just address, it's an interesting thing because we kind of, I think on the other podcast that you guys were talking about, the economic side of all of this too. So if you have prevention, if you catch things early on, you're actually going to, save so much more hospitalization rates and other. But also, I kind of want to get back to this idea. I wish that dental schools and medical schools really have a, like, I don't know what you call it, come to Jesus moment, for example, when you do your swearing of Hippocratic oath, because
Yeah.
because it's not supposed to just be we don't do harm, but we're supposed to do the best that we can for each and every
Good.
patient.
Yeah.
And now patients come in with a myriad of clinical history, background, prescriptions, and all of that. And I kind of am really, really shocked that I'm not kidding you, over 90 to 92, 3% of calculated, because I just say every 10 patients, I ask them, did your primary care, your sleep physician, or anybody take the time to go over your sleep test with you? Oh my God, Nicole. I mean, like, they go, no, nobody told me about. I said, okay, so first of all, do you know what this AHI, what this RDI, what this heart rate variability means, what the oxygen desaturation means, and I'm kind of explaining them like, this is constant fight or flight. I mean, look at your heart rate, look at everything. And they're like, oh my God, like, no wonder. And I'm thinking, gosh, if I look at the amount of time that I spent, maybe it was, I don't know, 15, 20 minutes. I captured the patient's attention because then, they know, wow, I'm breaking their whole history down, but it also helps with their valuing what I'm going to do for them. It ends up being the compliance. It ends up being, and so like if we do any orthotropics or if we do an expansion, I also have myofunctional therapist that I hired to help me with that. And it's really this kind of this magic that needs to happen, and it can't be done in any type of. And so maybe I'm going to get in a lot of trouble for saying this. I think it's a joke, a big joke, to make dental sleep medicine a DSO model. I'm like, you got to be kidding me, right? Like, this is a medical condition. This is a condition that has comorbidities that spread everywhere, like we just discussed, and you want to make it more profitable by making DSOs out of it. I don't know. It just is something like, wait a minute. It goes back to the Hippocratic Oath again, where I think a lot of people, they want either fame or they want, oh, I did 100 cases a month or this and that, and I made so much money, and that's really, really the wrong message. And I humbly ask that those people that make those conventions and say those things to just stop it already, okay? Because in the end, I would rather have 10 beautiful, well done, thorough cases that impacted and made the quality of life of that patient, and follow through, by the way, as well, not just here's your plans, bye-bye, than to say I had 10,000 cases I did, and look how wonderful I am, look at how much money I made, right? So that part is really a sensitive topic, but I think that if we wanted to really make this needle move forward, and let the physicians and let the world know that we have the answers. And what a shame it would be. What a shame it would be that we really do have that ability to make that big of an impact, but yet, because we expand things too fast, because we create TMJ, TMD, because we don't follow up, and sometimes, if you put the oral appliance in the wrong position, you can worsen the HI, you can have more fragmented sleep, you can have a whole slew of things, and just like, and then people come in, and I'm being very honest. I love the fact that Inspire's done a lot of awareness and commercials, and everybody sees it. But there's also the notions of if you have a concentric air collapse, they have to do DICE to see that. Then you're not really qualified. You have a certain BMI index, you're not qualified. And also, I'm being honest, right? I'm not knocking Inspire at all, but some of my patients, they come in, they say, doctor, I have. Okay, so this is why I'm here, Doctor Who. I have more fragmented sleep with the Inspire because I literally wake up from the zap. I can't handle it, and no matter what levels. And now then I asked my physician, what can I do about it? And the ENT said, well, if we try to take it out, the risk of secondary infection would be greater. So we're just going to leave that implant there and just, leave it there for the rest of your life unused. And I'm thinking, okay. And so I'm thinking, why weren't you here first, right? Maybe with oral appliance or with orthotropics or, osteoremodeling before a surgical invasive thing, right? And why are we doing these major surgically assisted rapid pedal expansion cases like SARPI or MSC, which I know, okay, the evidence base is there. I'm supporting that, but let that be the right order, if I may. If you are a CPAP intolerant patient, then you're a non-responder to oral appliance therapy, maybe, and then think about, okay, what about these osteo bone grow coupled with myofunctional therapy, coupled with anything you can do, lifestyle, right? And part of that other leg too is these exercise. So exercise, for me to keep this bicep, I have to go to the gym, right? And so for these dynamic options, oh my gosh, myofunctional therapy, the big three, lip seal, tongue posture, nasal breathing, nitric oxide, those things are so key. But we're alive, okay? And if if I start eating McDonald's every day and I overeat, well, then yeah, I gotta maybe say, hey, kind of adjust that, kind of start eating healthier foods, go to Whole Food Markets, Trader Joe's, eat healthier. So it's like that too with even biofunctional therapy and with didgeridoo. If you want to play, if you're in Australia and you love that, play it. The circular breathing and the embouchure of that instrument is going to help tone those pharyngeal muscles, right? Or a clarinet, or not clarinet, excuse me, English horn, double-winded English horn, or a bassoon or something like that. Anyway, there's evidence base for that. But anyways, those things I think are so important because again, we got to stop the notion of here's an oral appliance, bye bye. Here's a denture, bye bye. We need to say, no, how are you eating? How are you doing the exercises? Do you catch yourself with your forehead posture, mouth breathing all the time? Or, are you following those pearls and those exercises and keeping your airway, your breathing, everything all in check, So that's kind of an important thing too.
Yeah, like addressing the four-leg table, right? All those pillars need to be addressed, and you can't address one pillar at the expense of the other ones, which is so true. And these issues are very complex, right? I know Dr. McCarty talks about that too. And he's going to be on as well that it's not necessarily complicated, but complex. There's so many different components to these issues. And we can definitely address all these components. Just the practitioners need to be made aware of them and what to look for. We've had cases where I had a patient referred by the ENT. The man was on CPAP and they increased the pressure so high that it's waking him up. So he can't sleep because of the CPAP. What can we do? Well, he has a nasal mask and he's a mouth breather. The ENT was not aware that you're going to have to bump up the pressure because the air is going to leak out of the mouth. I'm just thinking like, wow, you don't put a nasal mask on a mouth breather, or you get them to get lip seal. And that's where the myofunctional therapy comes in.
Totally.
And so I'm like, we're going to need to have you lower the pressure because now he's going to be having his lips closed when he sleeps and, things change. But I feel like there is a lot of disconnect among different practitioners and providers. It's like, I do my part, you do your part. But if our parts aren't intermixing, those details could be missed.
Yes, and you can actually even harm the patient. So I love the fact that you brought up this because I'm kind of a walking I don't know what I call myself. I'm just weird because it brings me thoughts about this new study. Right, it's relatively new, but these pulmonologists at Columbia University, they did a huge, wonderful study that talks about air pressures of CPAP of 7 or greater, and greater of 7 when that air hits the endothelial cell linings in the lungs, it will release angiopoietin-2. Angiopoietin-2, you ask any cardiologist, is a huge risk factor for heart attack and stroke. So when we're getting these people on CPAPs at grip pressures of 10, 12, and maybe a jet engine at 14, whatever, we're going to create a higher risk with angiopoietin 2 for heart attack and stroke. And
Mm.
so I think when you think about that, that study's out there. It's I don't know if it's kind of buried or people don't talk about it or they try to find something and maybe who knows because CPAP is like a several billion-dollar annual industry. There's a lot of things that is created in that disconnect where we have so many compartmentalization of healthcare. This is it's not. I just joke about this. I don't really think this, but Roger on that podcast was thinking, what's going on with all of this, with the technology, with all of this dysfunction becoming the normal new function. Maybe it's just world depopulation. I'm just thinking everything you think about it is really a thing to end up with early death. I mean, when you have physicians not talking or not working interdisciplinarily, when we're waiting till all the symptoms and everything are full blown versus catching them early and preventing them, when everything, and then you have, especially now, inflation and economical obstacles right now that can make people and so what a wonderful blessing it is, like for example Roger to go to Romania and to do these countries that can really even show that if we address it earlier, there won't be, no, I'm saying that people who probably rely on putting band-aids on and doing a lot of, treatment
Yeah.
for money, they're not going to like this because you're going to, because he says prevention's no money, right? And
Right.
I can't
Right.
agree. But then again, I just wish that everyone had that notion where before we're, on our deathbed, that we've done something to really be why we became a doctor or why we in healthcare. Why did we become a hygienist? Why do we, in the first place? We're supposed to help people's quality of life, their healthcare, their oral, all of that, right? And so I really hope that is there. But you're absolutely right. I think that the notion of my being on here, the two things, if I can really make sure people get, is that first to understand all the options that are out there and really think about them from being the least invasive to the most invasive. Think about the cost and the parameters, but also anybody listening, of course, they would be obviously interested in airway and sleep, is to really do everything that we can to stick together. Now, again, sticking together doesn't mean defending companies that are just out there to make a quick buck or people who are trying to drive things super fast and not following protocol or doing whatever motives that they have. No, of course, we need to be against that. But for the understanding that we need to help each other, defend each other. For example, like that $10 million lawsuit on the CBS News, rather than seeing companies, clapping their hands and saying, ha ha, we're glad that company went down. We're glad that lawsuit, instead of that kind of negative, like, vibe, be more like, hey, you know what, we're in this together. That was a very specific case. It has nothing to do with the actual protocol and the tens of thousands of people who've benefited also from using this type of appliance and this type of a cookbook recipe versus that, because in the end, when we have the public scared or they have a label or a judgment, then all this really really good stuff to benefit their life is not available. And again, every phenotype, every medical history, every economical condition is so unique to every person who walks in the door, whether they're adult or a child, right? Because again, like if they're a child, I totally agree. If you get parents who have the money, but they're not going to be a part of helping out, and they're going to just, kind of uh, uh, take the responsibility off their hands and move it on a babysitter or a driver or something like that. That ain't going to work, right? We need to make sure that we have the support and to really educate and bring the awareness to the public that we can help improve quality of life and increase lifespan and do all of what we're supposed to do anyway.
Yeah. It's so amen. I mean, that is so true. And I also feel like a lot of the practitioners that might be, like the ENT I was just talking about, who was like, help my patient. It's maybe just lack of education awareness, but good intentions, right? So that's
Yeah,
why I think we have to spread the awareness. It's not always like, let me take the quickest, uh,
you.
cheapest route out for me, but make me the most money. I think people just
Yeah,
are uneducated in the big picture and
yeah,
maybe sometimes right narrow minded, like narrow focused, and don't know about the other specialties and how it's not just we can work together and it'll be better, but we have to work together in order to achieve positive outcomes. And I know that ENT was very thankful when his patient got better by some simple steps to help him sleep with his lips closed and
Right.
muscle straightening exercise. Patient was happy. ENT looks more successful because,
Yeah.
we work together to help the patient. So, obviously there are practitioners who are just into money and fame and, let's build this one business or whatever. But
Yeah.
I think the majority, it's a lack of awareness, probably.
Yeah. I
There's probably so many physicians who have no idea what myofunctional therapy is, or,
right. Right.
what
Yeah.
how we can all help. Wow, this is so much information. This was so just educational. No wonder why you have so many letters and credentials after your name.
Oh,
You're like
well,
a walking brain and a walking muscle.
so let me give this for dentist, okay? And so when I lecture, this is how okay, and this is a true story. Okay,
Okay.
so now I'm always by the book because obviously I follow cookbook. So when I got into implant dentistry, okay, this is before I got into Airway, dental sleep medicine, and I actually have slides that I show up. It's kind of the wow factor because I like to get people's attention. And I said, okay. This patient presented with partial edentalism with functional deficit. Okay, and so I have a clinical pre-op photo, and there were so many root tips there, so many abfracted teeth, so many green stick fractures. It's just like a mouth was a mess, right? And I'm now credentialed in implant dentistry. So Jerry's going to do this implant stuff and get the patient function back and blah, 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 blah. Okay. So, and that time, the Nobel Active implant was just new. And it's like, wow. And it's 𝐃𝐈𝐒𝐂𝐋𝐀𝐈𝐌𝐄𝐑, it's not titanium, but I follow all the protocols and guidelines. And so after bone grafting, there's 3 months of a way to let the bone take, make sure it's great. Then after the osteotomy, the implant fixture placement, 5 to 6 months, wait for osseointegration, don't load it. I mean, everything a textbook. And these implants I put in, they were in function, right? Okay. So for a year and a half, okay, now this is where I don't know sleep, right? And I didn't say to myself, well, why did the patient present with abfractions and green stick fractures and root tips and crowns broken, fractured everywhere? Like I just go, okay, well she's just a stressed person. She's bruxing and whatever. Maybe she clinches, whatever. Just think, okay. So okay, I'm gonna put these implants in there. I'm gonna restore them. I'm gonna put them on the long axis where the load is there. I'm gonna take light occlusion and do all my micro occlusion contacts, the centrics, and everything like that. So a year and a half later, after in some function, she came to my office in Alaska unannounced in the morning, and the front desk called me and said, doctor, you need to come. So she opened up her hand, and it wasn't an abutment, it wasn't a crown, it was half of the implant with soft tissue and bone and blood and abutment and crown. I'm like, oh my God, you got to be kidding me. I said, if I were to give you, Nicole, a 𝐃𝐈𝐒𝐂𝐋𝐀 implant, and I'll give you 10 years to use your hands to break it in half, there's no way you can do it. Okay. But, okay, if you think about it, all the forces at night, when you're awake, right? General dentist, you check border movements, you check, with the articulating paper, shim stock. But at night, we know that during REM, the body, the atonicity of the muscles, right? The gravity, we're like this or that or whatever. There's pitch, roll. Yeah, there's so many dimensions that you don't check while the patient's awake. So even if you think you have it just on the long axis, you don't have it in high occlusion or whatnot. You have it all centric, no torque, no premature contacts, blah, blah, blah. At night, because survival ability is number one, right? We are going to try to brux, do whatever we can. It's a movement disorder classified by the AASM. And it's going to try to fight for a patent airway. And by gone it, if the tongue, if the jaw, if anything's in the way, it's going to load that. And it's not one night, it's a year and a half later. It's night after night after night. And of course, when you have an implant, you don't have sometimes it's like a root canal. You don't have all the sensitivity and whatnot. You don't have cold, hot, whatever, because it's an ankylosed implant, right? So the patient wasn't saying anything. And then, but literally came to my office and I'm thinking, holy cow, right? And so I had the extra, she fractured in half. And then a year later, a patient moved up from New Mexico to Alaska. Same thing. She actually had a fixed implant denture and it fractured with the implant in some bone. And so I'm
Oh,
thinking, what kind of load would that be? But the whole story was there. The presentation of that patient from my original photo, I'm like, holy cow. she did this to all her teeth. She has, two bicuspids missing here, three molars missing here, this canine's missing. It's all, broken down roots. So those forces, again, airway wins. It trumps everything. Our body is going to do whatever it can to survive, and it's the night after night after night, and then of course daytime too. I mean, if you have issues where you're not breathing well or appropriately, or you're stressed or whatnot, and I do believe totally in daytime orthotics. Actually, a lot of the protocols now for osteoremodeling, and Michael Gelb has the airway centric, and his father Harold Gelb, like one of the pioneers. You have Ricketts, you have Ed Spiegel, you have Harry Sugg. A lot of these, and now even the current orthodontists like Paul Serrano, Brad Eli. All these people are really, really for 40 years, addressing all these issues with airway, and knowing that it really involves everything, all of us, to work together to come to an endpoint. Whether you think you're a dentist who is doing restorative dentistry, and I never have to worry about airway. Your crowns, if that can happen to an implant, your beautiful smile makeover that you just did, your wonderful veneer that you did, or whatever buildup that you did, it's very, very much vulnerable to forces that can be pitch, roll, yaw, diagonal, in every direction. Yeah. So,
And why did you have to do that smile makeover? Oh, because there was probably muscular dysfunction to begin with. That person
yeah,
probably wasn't breathing well.
yeah,
Jaws didn't grow correctly, right? So even just looking back at the root cause and the why.
yes,
But the masseter muscle is the strongest muscle in the body.
yeah.
So I
Oh,
think of like caveman days, are ripping like meat off bones or whatever, like raw meat, like killing animal, whatever, where just that muscle needed to break apart tough, thick, chewy foods.
yes.
And the weird, like, kind of dichotomy is that bruxism is that patient fighting for a patent airway. That's the wording used, which I really like, that fighting for a patent airway. And if the patient wasn't bruxing, they might have stopped breathing even more.
And,
And Dr. Simmons says this. I always think this is interesting, right? We know that bruxism could be like self CPR. And Dr. Simmons notes that patients are, we know they're bruxing, kind of like saving their life as the oxygen's dropping or brain is arousing from sleep, right? Muscles are tightening to help open the airway, or a response, that tongue thrust and mandibular response, that reflex, right? Coming forward to help open up the airway. Well, Dr. Simmons notes that patients who start reporting they become very tired happens around the same time that they notice they no longer grind their teeth. So
mhm.
interesting, but as he's interviewing patients and they say, "Oh, I used to grind my teeth." And, he says, "Well, when did you stop?" Probably 5 years ago. I don't think I'm grinding anymore." "And when did your tiredness occur?" "About 5 years ago, I started getting really tired," because their body's kind of giving up, right? And then they're not breathing. And that's a really interesting thing. And when he told me that, I started noticing as I interview patients, looking at that correlation and that factor, because some patients are unaware that they're grinding or clenching their teeth when they sleep. They have no idea. You can just see the dental wear, or they might wake up with like pain or tightness. And others are aware, but we have a lot of patients who say, "I used to, I don't grind anymore." That's actually almost worse, right? A big red flag.
Love that sentence, and you brought that up, because if you kind of think about how our body is so amazing, it tries to compensate. I mean, even like with my dad, his heart grew bigger to try to compensate with a congestive
Yeah.
heart failure and the Cheyne-Stokes breathing stuff. But because we're human, and one thing we all have common is death, eventually our body's gonna give up. And when it gives up, you may have, quote unquote, the superficial alleviation of those symptoms and stuff like that. But if you're not addressing the hardware, and I think too, and there's one other person, this Victoria DaCosta, she's brought a really thermal imaging into equation, where she's looking at the biomechanical, the bioelectrical, and then the electrical mechanical, and the bio something else. My
Yeah.
mind is sometimes cluttered. But anyways, when you put it together, I think our body just kind of, even at birth, right? Like, if depending on if you are breached or whatnot, and how were you breastfed, were you, and then again, there's some literature out there about koala hold versus westernized hold, and also when are you putting solid foods in, and when, so many things, and all the preservatives and all that. all those things, our body kind of just says, okay, we're going to do this one fight, one fight. Eventually, it's just going to say, you know what, it's too much, and we're just going to give up. And when it give up again, it's there's no way to prove it, but I do think that it is taking lifespan away from you. You're going to have an early death. So everything I like those tables that say if you don't do anything eventually, what does that mean? You're going to die a lot sooner, than potentially what you can live to. Yeah. And so with the bruxism thing, I really do. I mean, I've witnessed it. I was over at the sleep centers all the time when I see these long apnea episodes. Then you see movement, and eventually you're like, it's always like at the end of this long apnea event, you'll see, like, and especially kids, if they have the tonsil or adenoid issues, and you can hear it, and it's just always a body trying to say, okay, I have a conscious brain, but the rest of my autonomic, the rest of me survival, that's going to kick in, because if it doesn't, then and the thing too is we know enough now that sometimes for an unfortunate few, I was talking to some NFL players and stuff like that. And there's, and that's just the Reggie White story. But there's also celebrities like Ray Liotta or Princess Leia or Carrie Fisher. When we tie in, their sleep breathing disorder and other issues, yeah, that could be the root cause of everything that happens afterwards: the heart attack, the stroke, the death. And they're the unlucky ones. The luckier ones may just somehow, compensate and overrid that, but they still have these issues. They may not have the bruxism, like you said, but this is maybe even end stage, like my dad. My dad, towards Alzheimer's stage 6 and 7, he wasn't around, but a lot of maybe the pain, or I mean, this is sad to say, maybe my dad still had pain, but with his Alzheimer's at that stage, he can't even express it, or you know what I mean? It's like, it doesn't mean that his body is healthier, right? Because then he died shortly thereafter. Stage 6 and 7 for my dad was about maybe 2.5, 3 months, and that's when all the diaper business and everything like that. But but if you look at, before stage 1 or 2, he'll say, "Oh, my back aches," or you would blah 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 blah. But stage 6 and 7, he was almost like a vegetable and just kind of didn't talk very much, but he was dying. And so I think what you just brought up with the Simmons thing is really, really, like, true. Yeah.
Yeah, I'm going to be talking to him specifically about bruxism. We're going to do an interview,
Mm,
and he's had really interesting points about like phasic bruxism versus tonic bruxism,
mm,
and the studies of patients who had the oh my gosh, why am I blanking on the word where you like take away the breathing, you put a breathing tube in here. What
right.
trachea. I'm like, what?
Right.
Tracheostomy or tracheotomy. And showing like it's the negative pressure in the airway that
Mm,
can trigger that reflex of
mm,
the tongue thrusting
mm,
reflex,
mhm.
mandibular protrusion reflex. Really interesting. So I'm going to talk to him about that. So stay tuned. Listen to that one too, because it's
Sure.
really profound. And we find a lot of our TMD patients, oftentimes those are the difficult patients because they're having a lot of psychosomatic issues
Yes.
and pain, and usually are getting misdiagnosed because they're missing the upper airway resistance syndrome diagnosis,
Yep.
probably because they're bruxing. That's why they're having the pain and the facial tightness and all that, but that's causing them to not be full apneic as well. So it's just an interesting way to look at these things. When you know about all those details, we can really see more about our patients than just reading a sleep study or going by
Please.
cookbook methods. Wow, really interesting.
Yeah.
As we finish, I just want to go over, you said the word chirodontics, and I think probably a lot of people don't know what that is. Could you just talk about what chirodontics is? You said that in the beginning.
Yes, yeah, chirodontics is putting dentistry, or more specifically, airway dentistry, with chiropractors, but chiropractors that are specialized in more SOT and postural. Now, AOs specialize in C1, C2 vertebrae. They're part of it, but it's not enough, because the SOTs really, really got a good grasp, because they look at the symmetrographs, and this is where they start working manually in the whole body to try to align things, right? So when you see you have a high ear side, a high eye side in your maxilla, or you have a fan face where it's opposite, and actually those different categories also mean how easy or how hard it is. Yeah, and so those chiropractors will work in conjunction. How that would start was the dentist would identify that there's cranial strains, okay, or there's side bends or there's torsion cases, and then they would refer to the chirodontist, and the chirodontist or chiropractor would align everything, level everything, do release, and then you would expand after. So you have to coordinate the appointments to where they would do their work, and then you expand, and it goes much faster. It gets more predictable. But also, there's certain phases of treatment that people have to understand. When you do neuromuscular dentistry or sacral craniosacral pulse, or when you do any type of microocclusion or nathology, that's phase 3. That's even after, like, correct. So the beginning, you have to address TMJ, immediate acute pain, and then you expand. But before you expand, once you level everything, it expands more predictably, much faster. And it's crazy. When one day when we're at a conference, I'll show you some of these photos before and after. It's not just expansion. When you look at these patients, if they have a high eyesight or if they're canted, they're completely level, and they're, you can see the expansion as well, but everything about them. Then you see postural photos. It's holy cow. I mean, you'll see big, long time forehead posture, or they have kyphotic, and you'll see the before and after, and you're like, you gotta be kidding me. There's no surgery involved. This is all non-invasive, right? And then now, when you create the gap, for example, when you have a cricket, for example, and you have a unilateral block, technically we're made to chew on one side, but since all the processed and soft foods, we chew both sides. When we chew, we allow so many signaling and so many transductions, so many things going on, and the body can balance itself out. So what's crazy is sometimes when you put these appliances in there, and all you do is you just monitor them, you make sure they fit, and if you need to expand, do a little bit of expansion on them. But you'll see actually after month 6, after month 12, 24, holy cow, these people will level out. And it's like, to me, the most beautiful picture, because you don't see this. You see most expansion cases, okay, they have all these cranial strains and these asymmetries, but they expand it and they just end up with a bigger, airway, but they're still lopsided. Everything's still kind of off kilter, and that's still, again, compensation. That's still just like that descending and ascending example. They still have an issue where their body's not balanced, and it's really crazy, because if you think about the sphenoid bone, the butterfly, and you think about the greater lesser ring and the greater ring and how it's attached to the palate, and then you have all these things that are in that area, if you will, in the inner ear and all that stuff, the allergies and the rhinitis and everything else. Sometimes, yeah, you could do a turbinate reduction, you can do ENT, but a lot of it is really our occlusion, the maxilla. And then, okay, I talked about the highway, but that sphenoid, holy cow, that's such an important bone. It's another kind of a puppeteer, if you will, a gateway to so many aspects. And when you level that out, you have so many foramens, you have ovales, you have all these fissures. If you look at the skull from the occiput forward, all these things where cranial nerve this, cranial nerve that. I mean, even if you think about the vestibular ocular cranial nerve 8, and you think about the otoconia crystals inside the semilunar canals, that's what gave me my vertigo. I mean, these stupid little crystals that knocked out. I mean, I vomited for like 15 times nonstop, ended up in the ER, because if I open my eyes, oh my God, the whole world's spinning, and it's just all because of these nerves that are not happy, these, foramens and canals that they go through. If they're pinched, if you have, or sometimes it's a head injury, sometimes it's an accident, sometimes it's those things. And if you don't address those and you just expand, well, it's not enough. So syntax, the order of treatment, being patient, letting the body tell you the rate of expansion. As an orthodontist, well, I'm an orthodontist and I'm just going to do hyraxis and a rapid palatal expansion, and I'm going to do it at my own rate. Well, I'm a human being with my own opinions. I don't know that body, but if I don't look for what that body's telling me, kind of like what Roger said, then you can actually make things worse, and you can screw things up more. But if you actually understand and say, okay, well, this person may be a 2-year case, this person may be a 3-year case. And I'm working like with a Down syndrome kid in Alaska. Parents are wonderful, dad's a state trooper, and I'm like, forget all those windows of time. We're going to go slow. We're going to go at the rate, because there's behavioral, there's other aspects, there's the parents getting in and involving themselves. In Alaska, I'm sorry, like, Nicole, there's no myofunctional therapist. I mean, I'm trying to get my hygienist to do some
Yeah.
do their programs and stuff like that, but they're wonderful people, but they're not like you or Renata or any of you, you wonderful peeps out there, so it's challenging, but again, that's where we kind of have to be realistic and be realist and say, look, there's definitely no. We want to have successful, thorough cases that are followed through. Enough with it already. Let's have 100 cases so we can go on stage and brag about how much money we make. That's so wrong, okay? And so that's the most important message.
That is your word. You've said it. Yeah, no, that's great. Well, we went over time, and I treasure you for talking so much and giving all that information. And I thank you for going over on time. And I apologize because you probably have so much to do, so much knowledge to spread. And there's so much food for thought in this interview, hearing you speak. I think anybody should go to a lecture or read an article or something you wrote, because you have so much deep embedded knowledge in this field. Wow. I've learned a lot. I have pages and pages of notes. Like I just took a college course. It's amazing. No, I love this. I got to go back and read my notes and listen to this again. Really interesting information. And I do believe symmetry is important. And I had my expansion done, but I know I'm not lined up straight. And especially doing these podcasts, I could see, I'm like, oh, I never knew the right side is off. And my midline is off. It was always off. But I'm like, I always have a problem on the left side. My left ear gets plugged all the time. Headaches on the left side, because always left. And it's interesting. And the body.
Well, from your vision, your left eye is higher, your left ear is higher.
Come on.
Yeah. And then so if you were to have a homeal block, you would do it on the low eye side. You would have the actual block on your right side, and you would wear that at night. And during the daytime, you'll have a pod, or you have something similar that you wear 3 hours. Myself, I'm going to do that to me, because I have a lateral strain as well. I'm going to correct myself as well. My middle kid, he has a little bit of that going on too, so I'm going to do it a little bit. My youngest kid, I'm binator. But yes, so when I become symmetrical one day and I see you at a conference, then I can tell you about what I did, and I'll just kind of have you do it. And if it's non-invasive, easy, why not? Why not all be level?
I want to fix left side. So my left eye is higher?
Yeah, so from what I see here, so your left eye is higher, your left ear is higher, and your maxilla, I think. So the good thing, the
midline shift. I think my lower jaw.
So actually, your maxilla. Okay, so I think your left is lower. So you may be a fan face. So if you're a fan face, that's harder to treat, but it's okay. It's all the protocol.
But it's interesting. I'm like, something's not right, because I can always, my left ear is getting plugged, but it only started I think after I had my second son, 10 years ago. I don't know why I'm sure there's a reason. It'd be great. You and I will talk at the next conference. Let's go chat. You can help me get symmetrical, because we can't fix one part of the problem. Really, of course, the human body is asymmetrical in many ways, but we do want to try to achieve balance. Otherwise, we're going to compensate. And now I got a lot of work to do to uncompensate.
Me too.
It's not, we don't want to live in compensating, and I don't want to live with my ear plugged in neck things on the left side.
And one extra tab on that is just there's midline bones and paired bones in the skull, right? And so some of them actually rotate internally, and some of them flex and blend. So when you flex and bend the ones there, and you have rotation, you can imagine that when the cranial nerves go through that, that's when funky stuff like your ear thing and all those other things can come, because they're not even, they're not level, your occiput's off, everything is gone. So yes, being level, you can understand what that physical anatomy thing will be important to make it.
Interesting.
So
anyway, we're going to talk more later. That was great. Thank you so much, Dr. Who. We will talk again. I'll probably see you at an upcoming conference. And I thank you so much for taking time out of your day to speak to us and just educate everybody on this information.
Pleasure.
Thanks again.
Okay. Bye-bye.
Thank you so much for joining this episode of Airway Answers. I'm hoping some of your Airway questions were answered. Please feel free to give us a rating or a comment. And if you have any further questions, you're welcome to email me at nicole@airwayanswers.info, or check out our site at www.airwayanswers.info. Thank you so much, and join us for the next one.